Hello, I'm Norman Swan. Welcome to this webcast covering the new guidelines on the diagnosis and management of atrial fibrillation, which have just been released this year, 2018. And they've been done under the auspices of the National Heart Foundation of Australia and the Cardiac Society of Australia and New Zealand. And before I go on, it's important to acknowledge the traditional owners and custodians of the land on which we meet. We're broadcasting to you from Sydney, and the traditional custodians are the Gadigal people of the Eora Nation. So this webcast we have three speakers. We have Sia Connell, who's a clinical manager at the Heart Foundation, a senior pharmacist specialising in cardiology at the Alfred Hospital in Monash. Nick Zwaar is conjoint professor of general practice at the University of New South Wales, about to go to Bond University as executive dean of health sciences. We're in awe, Nicholas. And David Brieger, who's a professor of cardiology at the University of Sydney, Concord Hospital, and chaired the guidelines committee. So welcome to you all. Sia, you're going to kick off by talking about the guidelines, then Nick's going to talk about prevention and diagnosis of AF, and David's going to do arrhythmia management, stroke prevention, and integrated care. And then we're going to have a case study, and then we're going to have your questions. And the thing about your questions or comments is actually send them in now. As soon as anything occurs to you, put them in. We'll log it on my little machine here, and it's tiny little letters, but I'm sure I'll be able to read it. And how you do that is there's a ask a question box on your screen down at the bottom right-hand corner, or you can do it the modern way, which is at Heart Australia or hashtag AFib, so you can tweet your question, and we will avidly be following you on Twitter. Take it away, Sia.
Thank you. So a little bit of introduction and epidemiology of atrial fibrillation. It's the most common arrhythmia faced in clinical practice, and it affects up to 4% of the population in developed countries like Australia. It's associated with significant morbidity and mortality, contributing to up to 1/3 of strokes. It's also associated with 1 in 11 deaths in Australia. It also has a significant impact on healthcare resources, with hospitalisations, with atrial fibrillation patients presenting to hospital, 1/3 of them present to hospital each year. So a little bit about the guidelines. They've been developed for Australian clinicians for the diagnosis and management of atrial fibrillation for adult patients. They're informed by recent evidence and interpreted by local experts, which we have here today. And very exciting, they're the first Australian guidelines on the topic, and this is the copy here. The guideline working group was facilitated by the Heart Foundation in partnership with the Cardiac Society of Australia and New Zealand. The expert working group was a multidisciplinary group which comprised of cardiologists, an epidemiologist and physician, a pharmacist, nurses, a consumer, general practitioners, a neurologist, and a cardiothoracic surgeon. The reference group comprised of key stakeholder organisations and was consulted at various points during the manuscript development. We conducted external literature searches, and significant processes were in place to ensure transparency, minimise bias, manage conflict of interest, and limit other influences during the development. Importantly, we use the grade methodology, and I'll run through that a little bit now, as David and Nick will be presenting our recommendations using this methodology. The recommendations each have a quality of evidence. High evidence can only be attained if there's at least one good quality randomised control trial. And strength of recommendation is also provided for each recommendation. This incorporates quality of evidence, but also the potential for variability in patient preferences and resource considerations. So a recommendation can have a high quality of evidence, but be a weak recommendation if it's considered to be of limited benefit to patients. And vice versa, a recommendation can be strong, but with a low quality of evidence. The manuscript of this guideline underwent public consultation for 3 weeks and was reviewed by the Heart Foundation and Cardiac Society committees and boards. So now I'll pass over to Nick to run through screening and diagnosis.
Thanks, Sia. So yes, I'm going to talk a bit about screening and prevention of atrial fibrillation. We've got 2 recommendations here with the grade quality of evidence and a grade strength of recommendation. And the first one's about opportunistic point-of-care screening in the clinic or community. And this is very relevant to the general practitioners in the audience, but also a lot of other health professionals as well who would be in that situation where they might see people in the public, patients coming in who may be at risk of having asymptomatic AF. And the recommendation is that it should be conducted in people aged 65 years or more with moderate quality of evidence and a strong recommendation from the guidelines panel.
What does that actually mean, opportunistic point of care screening?
Yeah, good question. So that's if people come to see you for some other reason. If you're a general practitioner, it might be simply for a blood pressure check or for a routine medicine, maybe for their flu vaccine. And it could be an opportunity to do something fairly simple to see whether they may, if they're 65 or over, have asymptomatic AF, so AF that they didn't know they had. And the reason that may be important to do is that unknown atrial fibrillation is associated with about 10% of all ischemic strokes. So these people may not know they have AF but may have a stroke. So that asymptomatic AF is in close with increased risk.
And we'll come to the CHAD score in a minute. The CHAD score still applies if you're asymptomatic?
Yes, you would still apply the CHADS process, yeah.
And screening is a 12-lead ECG or just putting your finger on the pulse? Fingers on the pulse?
Fingers on the pulse, yes. Well, it's both. You need to do the pulse palpation first, and if you think this person's got an irregular pulse, then a 12-lead ECG is needed to actually make the diagnosis. Now, there are other smart devices, which David might want to talk about, which can do point-of-care, handheld ECGs. But as a GP, I know they're not common in clinical practice at the moment. But
Right.
there are devices emerging.
So just to be clear, so I put my fingers on the pulse.
Fingers on the pulse.
And I feel, to me, it feels like sinus rhythm, and it's not galloping away at 100 a minute. I don't need to bother doing a 12-lead ECG at that point?
No, if you think this person's in sinus rhythm, then that would be it. If you think this person...
So what's the fidelity of the fingers on the pulse and being able to accurately assess sinus rhythm?
I think the important thing is to make sure you keep taking the pulse for long enough. So I'd certainly...
So not 6 seconds?
Not 6 seconds, no. Certainly, that's right. I'd certainly do it for at least 15 to 30 seconds.
Right.
While you're talking to the patient, for example. It's a nice way to establish rapport. But you want to make sure that you're confident the pulse is regular before deciding that atrial fibrillation is not there.
Right. And is there sort of secret little symptoms that people actually have got that doctors may forget to ask about?
Well, I think that's a good point. I mean, some of these people may actually, if you ask, do you get breathless on exertion? Do you notice sometimes that you've got palpitations? They might say, oh, actually,
I do get the thump in the chest every so often.
Well, but, those things can be part of normal life too and getting older. But we are
doing a live webcast.
Yes.
Fatigue.
Fatigue, yes. Yeah.
It's very common that the patients will complain of fatigue. And that's something to think about.
Right. Sorry I interrupted. Well, I'm not really sorry, but carry on.
And the next recommendation is about probably a situation that's more involved with the cardiologist, is for people that have pacemakers or defibrillators, they should be interrogated regularly for atrial high rate episodes, which is ARES, and this should, if they're found to be present, confirmed by an atrial electrocardiogram to be atrial fibrillation. So that's just saying that people who have other arrhythmias can also develop AF, and those devices need to be surveilled for that.
I thought the pacemakers were pretty good at this, and you didn't really need to verify it. Did you need to verify it?
Yeah, I think they're getting better. They're getting better, and we're putting more of them in. And you do still see, atrial high rate episodes can be atrial fibrillation, or they can be supraventricular tachycardias too. So it's important to make that distinction, because you anticoagulate for one but not the other.
So here's my question. If you're doing opportunistic screening in the way you've just described, is it known that that makes a difference? Yeah,
that's, again, a good question. I mean, there's the cohort study, we haven't got a randomised trial here, is that those people we think are at the same risk as people who have symptomatic AF. But that's not entirely
So we've got to take
sure.
it on trust, in a sense.
Well, not just trust.
Well, we haven't got randomised data, but it's very hard to get randomised data in this context. But certainly the robust observational studies have suggested that if you follow a patient cohort that's been identified through screening, their event rates are comparable to patients who are symptomatic from AF, which is important and in contradistinction to AF that's detected on device screening, for example.
Okay.
And similarly, as we may talk about later, AF that's arguably detected incidentally on a handheld, on a Apple Watch or something like that. Aha.
Yeah.
I don't trust my Apple Watch. It's not even good for telling the time.
I think the other point I'd just like to make too, this is not, some things I think as a GP you're asked to do are very complicated sort of things that take a lot of time. Feeling someone's pulse, okay, it's 30 seconds, but you can do it while you're having a chat, as David said. So it's not as difficult an ask as some of the things that as GPs we're, you know.
And it's amazing how infrequently it's done.
Yeah, sure. Okay, we better press on. The next one we've largely covered because it's really just trying to expand out on what we meant by those things. So, this is about how to do opportunistic point of care testing. A device that actually gives an electrocardiogram is preferred because you need to see that to make the diagnosis. And there are sort of blood pressure devices that also give you a pulse readout, and then probably not quite as good as actually getting a proper trace. And then the implantable devices, we've talked about that, and the stroke risk factor assessment as well as surveillance for clinical AF should be performed following on if those atrial high rate episodes have been found on their device interrogation. So that's that one. The next one is about diagnostic workup and prevention. And the next point is about the recommendation that a transthoracic echocardiogram should be performed in all patients with newly diagnosed AF. The quality of evidence might surprise you is low on that one, but nonetheless the committee thought a strong recommendation was justified. And there's a number of reasons.
Why is it low? I mean, you've got to find out whether something wrong with the valve, don't you?
Well, I guess it comes down to the point that Sia made earlier. You need randomised trials showing that.
To score a high evidence quality.
It's one of the vagaries of the grade system.
Yeah, so it's all that, you know, you don't get randomised trials or parachutes, that kind of, you know, all that. And then the next one about intercurrent risk factors and comorbidities, including high blood pressure, diabetes, heart failure, valvular heart disease, alcohol excess. It's important to identify those, and they're a very important part of the management of people with atrial fibrillation for a range of reasons which we might explore as we go along. But in terms of the sort of longer term outcomes, of course, people's other cardiovascular risk factors for coronary artery disease, important to actually pay attention to those and seek to intervene.
And why alcohol?
I'll pass today on that, but alcohol's been shown to be a factor in both occurrence of AF and worsening of AF.
It's a cardiac toxin in simple terms.
And also not favourable if you need to be anticoagulated.
Sure.
Yep. Okay, all right. So this is talking a bit more about the transthoracic echocardiogram. And why would you do this? What would we find on it? Well, it could, of course, identify valvular heart disease, mitral stenosis or mitral regurgitation, and in particular, and to quantify left ventricular function and atrial size. And the transesophageal echocardiography is predominantly where electrical or pharmacological cardioversion is being considered or is going to happen, and to look for the presence of intracardiac thrombus, which may affect the timing of that procedure. So just differentiating out there the role of transthoracic echo in everybody and the transesophageal in a subset. And then the risk factor identification, which we've already alluded to, burden of AF increases with those at greater known risk factors, and there's several newer ones which are of interest, including obesity, sleep apnea, physical activity, and what we're calling here pre-hypertension. And as we've said, physician-led intervention of weight and other risk factors is important to reduce that burden, improve quality of life, including in people with paroxysmal AF.
What about thyrotoxicosis?
Yeah, well, that's an important one too, and there was some interesting debate in the group about, you know, the importance of checking the thyroid function, but checking it at a time when other reasons for abnormal thyroid function may not be present. So if a patient's acutely sick in hospital, you may not get reliable thyroid function results. You may need, and this is important for GPs who would probably be seeing people in the community who are less likely to be acutely unwell.
I think the yield of a thyroid function test in an inpatient is less than 1%, and the problem is interpretation of it when you do find it. The point that others have
So
made.
is it T4, TSH, the full battery, or just T4?
Well, I guess any abnormality of
Right.
you screen with a TSH and then you go on from there. But there might be a role if you're thinking about coronary angiography, for argument's sake. If someone has other features suggestive of thyroid disease and you're about to inject them with iodine, there's a potential risk for thyroid storm. So that's something to think about.
We'll come to diagnosis in a minute. I mean, is there a role for coronary angiography here, given that ischemic heart disease is the commonest cause?
No, there's not. That's a good question.
Or even coronary CT?
Yes, no. In the guideline, we didn't specify investigating for coronary artery disease, and the comment that it's ischemic heart disease is the commonest cause, I'm not sure that's entirely true. In fact, there is an association, but you would investigate these patients for coronary disease if you had other suspicious factors that led you to be concerned, like chest pain.
I've actually got a question here from Narelle Watterson, who's a nurse, asking, has a connection been found between childhood rheumatic fever and later onset of AF?
Well, there's certainly an association between rheumatic heart disease and atrial fibrillation. Whether there's been a specific association between contracting childhood rheumatic fever and later AF, I'm not aware of it, but it certainly makes intuitive sense that if you've had an insult that potentially affects the heart in childhood, it might become manifest as AF in later life.
Another question here, just while we're talking about risk factors, is a new study released has shown patients with depression have a higher risk of AF. Is that cause and effect or just association? What do we know about that?
Well, I guess there could be a whole lot of reasons for that. It could be that people with depression are more likely to smoke or to drink alcohol, or a whole lot of other things that may be a confounder of that association. Yeah.
Okay. As you were.
All right, I think we're moving on to David next and talking about arrhythmia management.
All right, I might take the advice from you.
There we are.
Thank you.
Yeah.
All right, so I'm going to talk now about the management strategies of these patients, and one of the major incentives for writing this guideline was to provide us with an opportunity to produce a document that was relevant to the Australian population. Previously, we've been looking to the Europeans and the Americans, and they've got reams of drugs that we don't have access to. So one of our incentives was to try and simplify things, which I think we've managed to do. One thing that's very important when we're identifying a patient with new atrial fibrillation is to decide whether we're going to adopt a rhythm control or a rate control strategy. This should be documented and communicated for all AF patients, and we should review it regularly. What drives these decisions are illustrated on this slide. You might opt for a rhythm control strategy, which means you're going to get them out of atrial fibrillation in younger, more active patients, particularly if they're symptomatic. Patients that have, I guess, present in an earlier phase of the disease, where it's paroxysmal or has only it's their first presentation. Interestingly, in patients with LV dysfunction, we might consider a rhythm control strategy, and that's informed by some recent data on the benefits of ablation in patients with LV dysfunction. If the left atrium is relatively normal in size, that predicts a better response, that you're more likely to get them back into sinus rhythm. And very commonly, rhythm control strategy is adopted in patients where you struggle to obtain control of the ventricular rate. Patients in whom you might adopt a rate control strategy are those with minimum symptoms, or those in whom attempting to maintain sinus rhythm is likely or are likely to be futile. So atrial fibrillation of long-standing, large atria, they tend to be the patients in whom we adopt a rate control strategy.
David, I want to comment on whether patients having to take an anticoagulant, for example, a long period would be another factor in the patients thinking about this?
That's a really good question, and we are very bullish with regard to our prescription of anticoagulants in patients with atrial fibrillation. If you've had an episode of atrial fibrillation and your CHADS-VAR score is elevated, there's a very strong argument for continuing on that anticoagulation in the long term, which, of course, we need to involve patients in that decision, and over time, there's two things that happen. The patients become more reluctant, but also the likelihood of the event recurring becomes greater. So it's a discussion that we're frequently having with our patients. This slide is a nice diagram that depicts the way we manage patients in whom you've adopted a rate control strategy, and it describes the choice of therapies. So
can I just put a pause button on there. What are you trying to achieve? I don't think we clearly discussed, because you were alluding to kind of patient-reported outcomes. What does the patient want here? Yeah. But let's just be clear what we're trying to achieve. Are you trying to prevent, is there any relationship for the prevention of thrombosis? If you've got, say you haven't got an atrial appendage, or are you trying to give them the best quality of life, or stop the descent into heart failure? I'm just not quite clear on what your goals are and how each strategy serves those goals.
Yeah. So in terms of controlling the rhythm, we've got two goals really. One is to control symptoms and improve quality of life for that reason, and the second is the issue around stroke. As I've alluded to, the stroke question becomes somewhat moot because for the most part you will anticoagulate them regardless.
Assuming they've got the right CHAD score.
Of course, yeah. And the data that have compared rhythm to rate control have interestingly not shown a huge difference certainly no difference in terms of prognosis for the most part, with the exception of the small ablation study that we might talk about later. But and interestingly, not so much difference in terms of symptoms either. But there were some vagaries around those studies with regard to who was included. So very often, very symptomatic patients were not included. And that's a problem with randomised trials, as we know. If you're very symptomatic, the physician is not going to and the physician believes that putting them back into sinus rhythm is going to cure their symptoms, that's what they'll do rather than randomise them.
Okay.
So these are the other therapies that are available, and people would have had time to look at this slide, I think, during that discussion. First...
well, people can probably see the slide better than we can.
That's right, yeah. The first issue is to determine left ventricular function. And in a patient with known normal left ventricular function and no evidence of heart failure, you have two options as your first line, either beta blockers or the non-dihydropyridine calcium antagonists.
So this is preserved ejection fraction?
Yeah. If left ventricular function is impaired, then beta blockers are your therapies of choice. We don't like using the calcium antagonists in that population because they impair left ventricular contractility and can precipitate worsening of heart failure. The next agent that we recommend in patients if rate is not adequately controlled is digoxin. This was somewhat controversial because there's been quite a suite of observational studies suggesting that digoxin in certain contexts can be harmful, particularly increasing mortality. But we looked very closely at those data. And we also looked at the evidence in the context of practicalities around clinical practice. And digoxin is actually, whilst it has its limitations, it's quite effective at controlling rate when added to additional therapies in suitably selected patients. One important caveat that we've included in this slide is to ensure that the drug doesn't accumulate. And so that involves measuring digoxin levels. The level that we identified as being safe is less than 1.2 picomoles per whatever the unit is. And that's an important message that we reiterate throughout the guideline.
Just get the measurements right here. What are they?
Nanomoles.
Right.
Yeah.
That's the pharmacist. Yeah.
Right.
And the other thing about DIG is in those really hypotensive patients, you don't really have many other drug options for rate control.
That's true, and especially if you don't want to give them a shock. So
and ivabradine doesn't work here.
No, then that's very important. The number of patients I've seen on ivabradine in atrial fibrillation to control their rate is staggering from among cardiologists. Yeah. So and then if in the infrequent circumstance where these agents are not working, you've then got the other options that are illustrated down below. AV node ablation with permanent pacing. The electrophysiologists in the panel were very keen on that strategy. It's something that those of us that don't practice it are somewhat more conservative with regard to using that.
Well, they've got mortgages to keep up. What do you want to know?
They've got kitchens to buy.
Yeah, that's right.
And then amiodarone. Amiodarone, a very effective drug, but gee whiz, it's...
I thought it was more for rhythm control than rate control.
It actually is effective. It is effective at controlling rate.
Acts on beta receptors as well. So if you're desperate, and you're right at the bottom of the diagram, so really hypotensive, critically ill patient maybe that you're...
But not a long-term option.
It's preferred if it isn't a long-term option. And certainly if you are going to use it in the long term, you want to minimise the dose. The rule of thumb that I use, or that we recommend, we actually didn't put doses into the guideline, is 100 milligrams a day for most patients. And of course, these patients are anticoagulated. So if you're fortunate enough that they cardiovert, the risk is not there because they're anticoagulated.
And what is the success rate of cardioversion?
Well, it depends on the population you're investigating. So if you take a new onset population, and I don't know that we might actually address it. I think we might address it. Perhaps I'll speak to that in the next slide because I think it comes up.
Okay.
Okay, well, in fact, I talk about long-term rhythm strategies, but at least with this slide up, we can describe each of the medications and how effective they are. So just to talk to this slide briefly, and then I'll answer your question.
Yeah, we can come back to it. I made a note.
Yeah.
Don't worry.
Okay, all right. So if you have decided on a long-term rhythm control strategy, you have several options. You could try and cardiovert them with these agents. And again, the first question is there structural heart disease? If you're confident that there isn't structural heart disease, and we've defined that here in terms of left ventricular systolic dysfunction, importantly moderate left ventricular hypertrophy or coronary artery disease, then if those features are absent, then you consider flecainide or sotalol. Flecainide is more effective and is probably the most effective of the agents that we have available in Australia.
But actually, the question about coronary CT before, and now you're saying that you do need to know whether they've got coronary heart disease.
Well, the issue with coronary disease stems from the CAST trial, which was a post-infarct population. It was conducted...
So it's based on history rather than testing.
Yeah. So we're talking about symptomatic coronary disease.
Okay.
Obviously, if you have any of those features present, then amiodarone is an option. One of the things to note about amiodarone is that, first of all, it controls the rate effectively. And the second thing is that it takes a bit longer to cardiovert patients, which is something I didn't actually know until we sort of explored these data. And whereas flecainide and sotalol tend to work a little bit more quickly. And you can follow the course of therapies on the slide down here. I've already alluded to, I guess, the issue as to which is the most effective. I've mentioned that flecainide is. Amiodarone is slightly less so, and the figures that I recall from the trials, that flecainide will cardivert between 60 and 80% of patients, I think. Amiodarone perhaps slightly less, 50 to 70. Sotalol, interestingly, not as effective as either of those two drugs, and there is an interesting meta-analysis or a Cochrane review that suggests that some of the other pure beta blockers can have an impact that may be comparable to sotalol, but those studies were small. But certainly, if you do opt for a beta blocker, you don't need to despair. It may be that you may, in fact, have some effect on cardioverting patients. Calcium antagonists, on the other hand, are not in this slide, and they're not effective at cardioverting. If you're unsuccessful with these therapies, then you may want to consider, or essentially we're talking about long-term strategies here. So if you've got patients in whom you've got episodic atrial fibrillation that recurs despite these long-term therapies, then you explore the option of catheter ablation, which is becoming more available and more frequently practiced in Australia.
How long do you wait?
How long's a piece of string? There are so many factors that go into that decision. Obviously, the central factor should be the patient. How symptomatic are they? And
presumably how well they're tolerating the medication.
That's exactly right, yeah. And they need to be provided with all the information. What's important to inform them about, though, is that catheter ablation is not a panacea.
What's the average number of ablations you need to get rid of the symptoms?
Yeah.
To get rid of the problem? Look,
I'm not an EP doctor, and they're probably... I think my understanding is that if performed by experienced operators, and of course everybody in Australia is good that does these procedures...
was that a smirk on your face or genuine?
It was what we're aspiring to.
Yeah.
And, we need to be sure that they are. But about 70% of patients will be successful with a single ablation. And then with a second ablation, the figure improves up to 80% plus. Of course, part of that is being very careful in your selection, I think.
And what's the risk of stiff left atrial syndrome following it? I mean, some people are saying we're going to have an epidemic of heart transplantation because we've got an epidemic of ablation and we're scarring the left atrium, and the only treatment for it is heart transplantation.
Wow, that's sensational, isn't it?
I'm a journalist.
That's right. So stiff left
You don't know the answer to the question, do you? I mean, it's a risk.
Oh, yeah, no, I know the answer. I'm just preparing myself.
Take a deep breath.
No, I mean, no.
David?
Stiff left atrial syndrome is a really interesting syndrome, and one that we're learning a lot about. I don't think we have a sense as to how much of an issue it really is. It certainly occurs, but and there's no doubt that in scarring the atrium in this way, you are causing some atrial dysfunction. But I'm certainly not aware of any data that suggests that we're going to wind up with a slew of refractory heart failures on the basis of stiff left atrial syndrome and heart transplants. Sure. I'm not aware of any data that suggests that. I'll just move on to the next slide. Stroke prevention. So the first change we made was a very simple one. And I think because we're in an opportunity to do this because we were local and we didn't have to bend to the wills of some of the strong guideline writers internationally, it was very clear to us, and all of you that practice will realise, that it seems ridiculous that we have different scoring systems for males and females when effectively we're doing the same thing. And so we decided to eliminate female sex from the CHADS-VASC score, so that...
Which potentially undertreated women.
Well, the argument is that we're not. And the logic for that is that that female sex, in fact, is not an independent risk factor. It's actually a risk modifier, and it only becomes evident in patients who have another risk factor. So what that means is that if you have CHADS-VASC 0 and you're a female, your risk of stroke or systemic embolism is not increased over a male. If you have CHADS-VASC 1, the same argument applies, and you're a female, the risk is the same. It's only when you get to CHADS-VASC 2 that the risk starts to increase for the females relative to the males. And whilst that's academically important, and
it's not going to change your decision.
It doesn't, because you've already anticoagulated these patients. So it was a relatively simple decision for us to make, and we think it simplified things. This is just a reminder of the points, the definitions and points in the CHADS-VASC score. Frequently we're asked how they're defined, and it's important to make note of this. So heart failure includes both systolic and diastolic. History of hypertension is important, even if the patient's not hypertensive and is well treated, that's important. And the others are relatively straightforward. Vascular diseases as defined there. Interestingly, cerebrovascular disease is not included in the definition, but most of us would regard that as being a factor that should be considered. This slide just summarises the point I've already made, but the other important issue here is that you may decide not to anticoagulate a patient at a particular point in time, but it's important to review that decision over time, both because risk factors accrue as patients age, and so too does the prevalence of atrial fibrillation.
Just before you move off the CHADS score, Denise, who's a practice nurse, asks, if a patient has a CHADS-VASC score of 1, is it worth being on anticoagulants?
That's a really good question, and the jury is out. One of the things we tried to address in this guideline was to try and tease out the risk within that CHADS-VASC 1 cohort, which is quite a large one, and it was not possible to do so. So in the end, what we've recommended and what others have recommended is that you have a discussion with the patients whereby you present them the risk of stroke, weighed up against the risk of bleeding, and the associated lifestyle limitations that anticoagulation imposes. My default position as a cardiologist is generally to opt for anticoagulation for the most part, but we haven't got...
But if the patient doesn't want to take it, they're not going to take it, so...
That's true.
Yeah.
Well, I also wonder how many people would be on anticoagulation if we did it for everyone. It'd be a pretty large number.
Yeah.
So that's another issue too.
Yeah, and not potentially justified by large randomised controlled trials.
No.
Yeah.
So...
Yeah. Bleeding. So there's been a lot of discussion around bleeding, and one of the things that we've noticed over the years in treating this condition is that bleeding risk factors are often used as a reason not to anticoagulate. And we, as other guidelines have done, has tried to emphasise the fact that the purpose of identifying bleeding factors is so that you can correct them. And
what do you actually mean here? Bleeding diathesis, or what do you actually mean?
Well, we're talking about things like use of concomitant medications that can predispose to bleeding, hazardous behaviour, alcohol, as Sia had mentioned earlier on.
So history of peptic ulcer disease, that sort of thing?
No, not history of peptic ulcer disease, although if you do have a history of peptic ulcer disease, you have a much lower threshold for adding a PPI in concert with the anticoagulant. Elevation of blood pressure obviously needs to be well controlled. And the medications, particularly non-steroidals and those sorts of therapies, just be aware that the patients will often really dose up on those if they're symptomatic.
And rethink any concomitant antiplatelet therapy, which David's going to get to as well.
So I think that what we recognise is that patients at high risk of stroke are also at high risk of major bleeding, and that the net clinical benefit almost always favours stroke prevention over bleeding. So we tend to steer away from bleeding scores because we found the literature suggested they were used to sway people away from anticoagulation. And this basically reinforces what I've said before. We treat these reversible factors and they should be prioritised and assessed periodically in these patients. So what about which drugs do we use? Well, actually this slide just speaks to the recommendations which are consistent around the world now, that we should anticoagulate patients with a CHA2DS2-VASc score of 2 or more. There's a little argument about that, in whom, unless there are absolute contraindications to anticoagulation. In patients with a CHA2DS2-VASc score of 1, it should be considered. Patient preference is taken into account. And in patients who have a CHA2DS2-VASc score of 0, we don't recommend oral anticoagulation necessarily for the most part. I don't know that we've got a slide here, but the other important point to make about this population is the use of antiplatelet agents. And we, as have others internationally, no longer recommend antiplatelet agents for patients with low CHA2DS2-VASc score for whom, or CHA2DS2-VASc 0.
So what are we talking about here? We're talking about aspirin?
We're talking about aspirin. We're talking about aspirin. We're talking about clopidogrel. We're talking about the combination. The aggregate evidence would suggest that what these drugs do is increase bleeding without impacting on the stroke risk.
Do we know why?
Well, I think event rates are low overall in these cohorts, and as it happens, their ischemic event rate is so low that this low background rate of bleeding, which is to a large extent a factor of our lifestyles, isn't it? Just outweighs the risk of an event, ischemic event. This slide illustrates the choice of therapies and again just reinforces the comments made previously. One important thing that we highlighted, because sometimes it gets lost, sometimes people get sort of overwhelmed by the diagnosis of atrial fibrillation and sometimes forget about other concomitant conditions. So the only sort of cardiac conditions for whom warfarin, for whom we don't consider a NOAC, and for whom warfarin is recommended, are the patients with mechanical heart valves or those with mitral stenosis. The remaining patients with atrial fibrillation are regarded as what we call non-valvular atrial fibrillation. They're the ones put in the randomised trials, and they're the ones for whom we adopt this paradigm that's illustrated here.
So is that the only differential that you have in management between valvular, we presume the valvular cause of AF versus non-valvular?
Yeah, look, again, you have to evaluate the whole patient, and there might be other conditions for which there's evidence for warfarin, and you choose to use it and not, and that would take priority. I'm trying to think at the top of my head whether there are any anymore, because there were, but these drugs, for instance, pulmonary embolus was
Factor V Leiden maybe, or other clotting disorders. VADS, that's a bit specialised, but
Yeah, but as the new anticoagulants have penetrated into practice, we've got randomised data for most conditions now. So for practical purposes, these are the conditions to which we pay most attention. And we, as have others, we do recommend the new oral anticoagulants over warfarin. They're certainly a lot easier to use. You don't need to monitor them. You don't have to worry about the drug interactions. When I say you don't need to monitor, you certainly don't need to measure blood. You don't need to take the blood tests as you used to need to do, but it is important to monitor renal function in these patients.
And Dave, what about the patient who's sort of stable on warfarin and prepared to be monitored? Would you change them?
Yeah. Again, patient preferences really come into consideration here. We are quite swayed by the intracranial hemorrhage data. So if you accept that these drugs, for the most part, are probably equivalent in terms of preventing stroke and bleeding risk, the one area where they consistently perform, where the NOACs consistently perform better, is in the incidence of intracranial hemorrhage. It's an interesting observation. Before these studies came out, I wasn't even aware of the fact that I don't think any of us were, that warfarin was associated with an increase in intracranial hemorrhage. We just assumed it was related to their anticoagulant properties. But there is no doubt that warfarin's associated with at least a threefold excess in intracranial hemorrhage in this population, which is a devastating event. Not frequent, but a devastating event. That being said, many patients are prepared to accept that absolute small increase in risk, and they like the security of being on an agent that they've been on for a long time.
But it's also, if you know that your INR is 2.5 or 3, you're in the sweet zone, whereas you haven't got a clue where the sweet zone is with apixaban or dabigatran.
But I guess the argument against that is, so what?
Yeah, because they're reliable, less variable serum levels, less affected by any, wind changes like warfarin is.
But not reversible.
And I guess, yeah, except for dabigatran.
But I guess the other point is that we've got huge data from many randomised trials showing that even though you don't know what the sweet spot is, the outcomes are the same or better. And you've got observational data that confirms that. This, I think, is the final slide on anticoagulation, and it's the vexed area of what to do when we're combining anticoagulants and antiplatelets. And we have...
and why would you be doing that? Because of coronary heart disease?
Generally in our practice, it's because of concomitant coronary artery disease.
So you've got a couple of stents in and you need to be on clopidogrel.
Or you've got patients, yes, exactly right. You've got patients that present with an acute coronary syndrome and need to go to the lab and then get stented. Or even if they have an acute coronary syndrome without stenting.
So in triple therapy, you're turning off almost the total coagulation system?
You are, and it's an effective way of settling the coronaries down, but it's also a very effective way of causing hemorrhage. So increasingly, we've got data coming out all the time, allowing us to throttle back on triple therapy. There've been several trials that have come out specifically comparing warfarin and triple therapy with NOACs and double therapy, and they've been performed for rivaroxaban and dabigatran, and have both shown that the combination of the novel anticoagulant with a single antiplatelet is comparable to triple therapy. Is certainly comparable in terms of ischemia, but less bleeding.
Right. So they have an effect they have a similar effect on antiplatelet agent without necessarily strong randomised trial evidence for it.
Yeah. So these are randomised trials. The problem is they're not adequately powered to prove definitively that ischemia is as effectively prevented. But the problem is that we're not going to get those studies, and we intuitively know that the consequences of changing these patients over to warfarin and subsequently is just certainly associated with an increased hazard. We haven't yet got data for apixaban, and we can talk about that later if it comes up.
And can I just get on my soapbox here? The other important thing with the interpretation of those trials is to use the dose of anticoagulation, which is found to prevent strokes in large randomised controlled trials. So continue with those landmark doses, with 20 of rivaroxaban and 5 of apixaban. We are seeing people reduce doses unnecessarily, which increases the risk of stroke.
Oh, we're not allowed to argue, are we? We have to agree with
you.
You
can argue back if you want.
Well, perhaps in the discussion...
You've got full permission to argue.
Let's wait. We might discuss the dose of rivaroxaban a bit later.
Okay, let's...
I guess the other point that
let's do it now. We're here.
Well, the trial that has specifically addressed this issue with rivaroxaban used a dose of 15 milligrams, not 20.
Right.
And it showed comparable efficacy and certainly much less bleeding.
But not
Yeah.
powered to detect stroke.
Yeah, yeah.
A difference in stroke.
But in any event, if we're going to accept these trials,
So what's the percentage reduction in stroke risk if you're on effective therapy?
oh, it's huge. It's huge. So if you're not anticoagulated, your stroke. Let me turn that to say it another way. Your stroke risk is reduced by, in relative terms, by 60 to 70% if you're anticoagulated versus not across the spectrum, across the whole spectrum. So these are very effective drugs.
And that's a net reduction,
Yep.
allowing for
Yeah.
intracerebral hemorrhage.
Yeah, intracerebral hemorrhage, which is less frequent, but it is included in most of the endpoints. The other point I wanted to make about triple therapy is that in the context of stenting, we do recommend, each of these trials did continue triple therapy in the initial phase, so certainly for the first week or so, and then you throttle back and drop one of them subsequently. I'll keep moving. This is a very important area that we prioritise and highlight in our guidelines. We've got some terrific expertise in Australia, and I'd just like to mention the fact that we were very fortunate to have their availability for this part of the guideline. You can see these patients are very complicated. They have a range of comorbidities. And for the purposes of the guideline, we describe three fundamental aspects of integrated care. The importance of multidisciplinary teams, and you can see that we've got a pharmacist here who's heavily engaged in what we're doing, but similarly we've got nurses.
And giving you curry here too.
Oh, you know,
That's my job.
Totally, I deserve it, and it's what we need. Patient-centred care is, obviously we've talked about the importance of that, and increasingly application of e-health, which is quite an exciting area. This is a very striking statistic, though, that despite the obvious benefits of these drugs as we've described, up to a half of them will have discontinued anticoagulant therapy within 2.5 years of initiation.
Really?
Yeah, absolutely. We were really struck by this. The problem is treating an asymptomatic condition with a drug that has no impact on symptoms, as it is with hypertension, as it is with lipid lowering.
A drug that's scary to patients.
But it's scary to us. Stopping it is scary to us. And this slide just summaриses some of the data on recent studies focusing on strategies to improve adherence, which have been somewhat disappointing. But there's a very active work going on in various places around the world, also particularly in South Australia here, looking at clinics run by a range of allied health professionals and doctors, focusing on these patients in particular and providing them with the support that will optimise adherence and ensure that these patients don't stop these drugs.
I thought there was really good evidence in adherence in general for practice nurses' interventions.
Yeah, and that's true. What we searched in this particular guideline was the specific evidence around atrial fibrillation, and we didn't find the evidence to be as robust as it was in other areas.
Do you use your practice nurses for adherence?
Yeah, look, I think there's an important role in nurses can be the organisers of chronic disease care in primary care, as you know, and when that's done well, the systems for follow-up, recall, reminder can be very effective in helping people to maintain their focus on these sorts of things, and for population management in the practice, where you don't just worry about the people who come to see you, you worry about the people who don't come to see you, and you try to actively seek them out. So I think that those sorts of things have been, very helpful. And not all the work needs to be done by the doctor.
I think
It's on to me now.
it's back to Sia.
Yeah. So definitely like to take this opportunity to thank our amazing writing group who donated significant time and expertise over 18 to 24 months to write this guideline and ensure it was evidence-based and practical for all clinicians. And especially like to thank our fearless leader and chair, David Brieger, who donated countless hours after hours poring over the evidence and making sure everything was just so, and it wouldn't have been...
She's softening me up.
wouldn't have been possible without his dedication. It's also important to note we have endorsement from our key stakeholders in the provision of care in atrial fibrillation. The guidelines are available on our website for free. There's the full version in Heart, Lung and Circulation, and for some light bedtime reading, the executive summary in the Medical Journal of Australia. There's also other resources on our website, including those algorithms that David and Nick have referred to. And now we'll have a little bit of time for our case, so I'll hand over to
Oh,
Norman.
I'd forgotten about the case. Yes, let's talk about the case for a moment. So the case here is a 67-year-old woman who comes to see her general practitioner routine checkup. Past history includes she's got a BMI of 33, and her GP takes her pulse and finds she's got AF. Her heart rate's 75, but she's asymptomatic and no other cardiac history. We missed the boat here on screening. I mean, should she have been screened earlier?
Well, she's being screened today in that she's asymptomatic. And
so give thanks for what you've got, is what you're saying?
And
it's an opportunistic screen.
It's an opportunistic thing. And you know, she's 67, so she's over that threshold, and we sort of had to set a threshold of where do you know, where's the prevalence high enough to justify the effort and for showing benefit of outcomes. So this is really a case of screening in an opportunistic way.
So here's my question. We can do it around this case study, which occurred to me while we're talking. I mean, can AF, apart from sending off to an echocardiologist or an echo service, can AF be entirely managed by general practice without having to go near a cardiologist?
Well, I'm interested in David's thought. I mean, I think in rural, practice, I suspect that often happens, that people will do organise an echo, get the result back, and if there's not a lot of concern, so if, there's not reason to think, well, this person, has valvular dysfunction or ejection fraction is a worry, they might then do the CHADS-VAS score, and maybe it's only 1. And at that point, you might say, well, at this point, we don't need a cardiologist, or 0, So, yeah.
Obviously, I'm going to say that it's good if they can see a cardiologist. I'd argue it's better for the patient if you've got that access. The reality is sometimes you don't. And we're hoping that part of the reason for developing this guideline in the way that we have is to educate GPs to allow them to be equipped to do as much as they can without us. But obviously, if you've got access to a cardiologist, it's certainly worth at least one visit. To assess left ventricular function is important. We'll do things like we may put them on the treadmill to assess their exercise capacity to see if they truly are asymptomatic. And quite commonly, we find that they.
So would you do an echo, a stress echo?
Yes, we may, or we may do the two separately. We may do an echo and just an exercise test to see what their exercise capacity is, and that's very important, because we can calibrate their performance against age-matched controls, and in fact, it's amazing how common everyone will know how commonly people tend to limit their activities to their capacity.
So, what's the stepwise approach the GP might take here?
Well, I think there's this. We talked about, the assessment, and there's a whole lot of parts to assessment here. Now we've got a 12-lead ECG, and we've decided this patient has atrial fibrillation. We now have to think about, well, what are the risk factors and what's modifiable? Her BMI is clearly one of them, and we would aim to get that down to 27 if we could. 10% loss of body weight. We would think about alcohol. We would think about other cardiovascular risk factors. We think about a risk of developing diabetes. So there's a whole lot of things. And where does the role of the specialist come in, as we've been talking about, and where, at what point, for monitoring, follow-up, review, because risk will go up over time as she ages inevitably, particularly if other things like diabetes develop.
And what chemical pathology would you do?
Well, you need to know her electrolytes. You'd also want to know her thyroid function. We talked about the 12-lead ECG, and you would also, as we talked about, move towards doing the CHADS-VA score. So, there's a whole range of things here which... do
we have enough information here to do a CHADS score?
Not with that. We'd need a bit more, but we've got,
With what we've got, it's 1, but there may be things we don't know about her.
Yeah.
And are we worried about her rate at 75? It's up a little bit, but not huge. David?
No, we're not. And interestingly, the studies that looked at differing rate control found that even up to a mean rate of 100, there wasn't very much difference in symptoms or outcomes between patients whose mean rate was 100 and the mean rate was 70. In fact, 70 was a lower rate targeted in the particular study that evaluated that.
So is it clear So it's not clear we don't have enough information to know whether she needs anticoagulants. How are we going to manage the AF?
Oh, in terms of anticoagulation, I think...
Sorry, I mean, in terms of rate, rhythm, what are we going to do here? Rhythm control?
Well, I think we need to have a discussion with the patient. And I think what I would do is confirm that she's asymptomatic, and then and I'd probably do that in some sort of objective way. and then have a discussion about the merits of cardioversion versus just rate control, and coupled with that is a discussion around anticoagulation.
You got any comments on this story?
No, and I actually made a mistake before saying her CHADS VAR was 1. From that, it's 0. But with the CHADS VASC score used internationally, she would score 1. So it's a good opportunity to point out that her female...
67.
Oh, yeah, it is 1.
Age,
I'll correct myself back again. But yeah, she scores 1, so she could be anticoagulated depending on her preferences.
These are... If you follow the literature, these are the patients for whom we now have a real opportunity in terms of weight reduction, looking for sleep apnea, dealing with the hypertension. You know, we really should be looking aggressively at these people and controlling their risk factors as best we can, because we know that'll prevent.
And in terms of chronic disease management, as I said before, coordinating her care moving forward.
Yeah, you could do it. You could, do a chronic disease management plan and get others involved, and exercise as well. Important to know one here. Really.
Can exercise precipitate a worsening of AF?
Yeah, that's a good question. There's complex associations between exercise and atrial fibrillation. So we've got very solid data that in patients with paroxysmal AF, regular moderate exercise is effective at preventing recurrences. On the other hand, there's also some evidence that, particularly in extreme athletes, that overdoing it, as you do, can precipitate AF. And that's an active area of research at the moment. We're learning more and more about it.
My palpitations, Professor Brigger, are more than just
as you're
being out of breath.
That third marathon, that's what's going on.
I've got a couple of questions coming in. We haven't got very long left, so a lot of time left. So if you've got any questions or comments, please send them in now so we can get to them. We'll rattle through a few. We've got a tweet asking, what therapy would you recommend for a 30-year-old man with persistent AF who has a CHADS score of 2, occasionally breathless while on beta blocker therapy?
So what anticoagulant?
Well, what therapy would you recommend?
I guess cover arrhythmia management and the anticoagulation. He clearly needs anticoagulation, so that's solved.
Oh, well, sure, and I won't go into which one you choose. I mean, that's a different discussion. But I think
is it a different discussion for a 30-year-old? What would you do? What would you use in a 30-year-old? Does it make any difference whether it's dabigatran or a Pixaban or? No,
in my view, it doesn't.
Right.
In my view, it doesn't. No, but he's young and he's active. So I think we need to have a fairly serious discussion about rate versus rhythm control for him. And my default position would be to opt for for rhythm control. I think most would in that age group.
With flecainide to avoid the long-term side effects of amiodarone?
Certainly wouldn't be opting for amiodarone. So flecainide is not a bad option in someone who has paroxysmal atrial fibrillation and a structurally normal heart. The important point to make about flecainide, though, is that they need to be on a rate-controlling agent like a beta blocker or a calcium antagonist at the same time. And the reason for that is that occasionally flecainide can precipitate, if a patient goes into flutter, flecainide can precipitate rapid conduction of flutter, which can be very dangerous arrhythmia.
So it converts to ventricular. You get ventricular breakthrough then.
Well, what happens is you get rapid. The atrial rate is going at 300. If you conduct at that sort of rate, you'll go into ventricular fibrillation. Right. So these patients need to have some sort of AV nodal blocking agent on board at the same time.
And why does a 30-year-old get AF?
Well, there are a range of possibilities. We used to talk about the lone AF cohort. These were patients who often had a family history, had no other structural heart disease, and got atrial fibrillation. Increasingly nowadays, it's often related to alcohol. It might be related to other lifestyle issues like obesity and sleep apnea and the like.
Amphetamines?
Well, that's certainly something to think about.
And that guy had a CHADS VAR of 2, so he must have some sort of risk factors going on. He might even have had heart failure.
Another question, it's all nurses asking questions tonight.
We love nurses.
That's right, we do, and it's great that you are. Are there any long-term considerations, apart from bleeding, for use of anticoagulants?
Are there long-term concerns? Far and away, the benefits outweigh the harms, and the important point to remember about atrial fibrillation is as you get older, your risk of stroke increases. So that's sort of foremost in our minds as we're treating these patients.
So it's the downside of not co-anticoagulating is the concern.
Yeah.
And is anticoagulation indicated after ablation?
Yes.
Another question.
Yes, I mean
that's for a doctor. So.
Well, no, it's a very good question. It's a very good question. Surgeons in particular will offer an ablation during their procedures and will very commonly stop the anticoagulant and tell the patients they don't need it. The data for the effectiveness of surgical ablation is even less robust than it is for percutaneous ablation. And our view is that these patients should remain anticoagulated because the recurrence rates, as best we can tell, are not insignificant, and the consequences are, of course, significant.
To what extent does the presence of an atrial appendage change your management?
That's a very good question. There are some data. There are some surgical studies that show that ligation of the appendage can have an impact on AF. The problem is that very often that ligation is ineffective. We haven't really got enough randomised prospective data to show that effective ligation of an appendage.
But what about you've got a CHAD score of 1 and you've got an appendage? Would that swing you to anticoagulation?
You mean most patients have an appendage?
No, I'm saying let's assume, does having an appendage make you more likely to put patient on anticoagulants?
So everybody has an appendage.
But I thought,
everybody has an atrial appendage.
I thought it was. Sorry, well that's my mistake. I thought.
Oh, no, that's fine. No, but everybody has an atrial appendage. So there are two ways of.
So it's the size of it we're talking about.
Well, in fact, the appendage is often the source of the thrombus, and so very commonly there are atrial appendage occlusion devices, which is another discussion that have been used to prevent in patients who can't tolerate anticoagulants, and the surgeons will often cut out or ligate the appendage during surgery. The problem is that that strokes often occur in the absence of an atrial appendage, and so for that reason it doesn't cure the condition.
Yeah. And persistent foraminal velar and AF. Does it make any difference to management?
Well, no, it doesn't. The issue there is the risk of stroke, and obviously, if you've got atrial fibrillation, you're going to be anticoagulated. So the only implication is that if you're thinking of closing it with the goal of avoiding anticoagulation, I'd suggest that that's flawed logic, because you need to anticoagulate a patient if they've got AF and their CHAD's VAS score is high enough.
We've just run out of time. But there's a quick question I need to ask you because it's important. From a rehab nurse, does cardiac rehab make any difference to the outcome of the AF?
Yeah, that's a really good question. I have no doubt that the attention that these patients receive with regard to risk factor control and adherence with medication has to benefit. And I think the way forward for these patients is to leverage off the resources that have already been directed towards chronic care. Prevention and provision of cardiac rehab to patients following acute coronary events and revascularisation. I think we should and heart failure. We should leverage off those resources and engage our atrial fibrillation patients in the same way.
Well, I'm getting kicked under the table here because I've run over time. Can you thank you all very much indeed for joining us? That's fantastic. Really interesting programme. I've learnt a lot. And thank you also for joining us in such large numbers and such a multidisciplinary group of people. It's great to see you also interested in atrial fibrillation. You can get more off the Heart Foundation's website, and you also we'd appreciate it immensely if you'd fill out the survey form to give us some feedback on how you think this has gone. Thank you very much. Good night from me, Norman Swan.